Welcome back mbukeli. Sisaqhubeka nalo udaba lwethu le-prostate cancer kubo babe. Dr Mthombeni.
Yebo dokotela.
Njengoba besishilo ngaphambi kokuba siye ekhefini. Kunalento abodokotela abayenzayo kuma patient ukuthi bafake umuno lapha emuva. Nisuke nenzani? Nisuke nifuna ukuzwa ini kahle hle? Ngoba kunemyth abanye bokuthi mabangakupressa lapha na hayi induku seyiba right iyavuka. You know kunezinto abasikhuluma nje ngodokotela.
Yeah.
Ngicela usichazele nje ukuthi nisuke nenzani.
Okay, so what you are explaining to the viewers basically is what we call digital rectal examination.
Yeah.
So it's describing basically. So what we do, the patient lies down on a side, and then basically we put a finger into it through the anal canal, and then we feel the prostate there. So the purpose of doing a digital rectal examination, you want to feel how the prostate is. You want to feel does it have nodules? Does it have, if it does have nodules, are they like involving the whole prostate? And where do you feel them exactly, Lapaya? So in that manner, by doing so, it allows us to locally stage the patients, because you know, okay, there is a small nodule there. Or maybe there's two nodules there and there, and then that is very like significant in how we stage these patients and actually what is the word, decide on the modality of treatment.
Okay.
Yeah. So we use it for basically for follow up to check for disease recurrence, and also for staging purposes.
Okay.
But there is also data that says you can use it to screen patients, but obviously it's a subjective, clinical examination. So what you may feel is not what I might feel. So we don't really recommend it for screening. So rather the PSA.
Okay.
Yeah.
No, usichazele kahle kakhulu dokotela.
Yeah.
Manje sibuka la dokotela. Kukhona ama risk factors ubale ukuthi uma kune family history lo umuntu ngabe akhona yini amanye ama risk factors?
Yeah, so basically, like if for example, my father had cancer of the prostate, then that's a risk factor on its own, isn't it? And then, but those cases where there's in a family, there's germline, what we call germline mutations, you understand?
Okay.
So there's what we call things like BRCA mutations, BRCA1, BRCA2 mutations, things like Lynch syndrome.
Okay.
So those diseases, like for example, the BRCA1, BRCA2 mutations, it's what we call tumor suppressor genes.
Okay.
So what they do, like we spoke earlier, in the regulation of the cell division, those mutations are there to sort of regulate the cell division process. So if those genes are mutated, that process keeps on going. It's never like halted. So in anyone with a confirmed history of a BRCA or BRCA mutation 1 and 2, is definitely a high risk. You have to start your screening at an early age. Because your likelihood of having prostate cancer if you are male is very high, likelihood of having colorectal cancer, pancreas cancer, and breast cancer. So also if there's a family member or a first degree relative with any of these cancers I've mentioned, like colorectal, pancreas, breast, then that is also a risk factor, as much as it might not have been confirmed per se, like that there is a specific mutation or gene running, specific germline mutation running in the family. So these type of syndromes are the problem.
Okay. Asingene ku treatment dokotela. Iyalapheka yini I prostate cancer?
Yeah. So prostate cancer iyalapheka, fortunately. It's a slowly progressive disease. Yeah. So how it depends is that like the sooner we catch it, the better. So that's why we are preaching about screening, so that when we catch it early, then we can actually cure the disease. So how we go about it, it depends on the extent of the disease. So like I've mentioned, Kalen, is that the prostate is local. The disease starts locally, rather. So when it starts locally, it can spread to other areas. So if it's a more of a local disease, we are able to cure it. So to treat this disease, we have to. It's a multidisciplinary approach, like essentially to treat. We have to have urologists, oncologists, basically radiation oncologists. Well, clinical oncologists as well, and essentially that's what you require. So depending on what they find, or what because that specimen after removing, it has to be checked, isn't it? So depending on what the parameters or what was found after it was removed, then I, as the oncologist, will have to decide whether I have to give this patient further treatment or the surgery on its own is enough. So surgery is one wing, and then also there's radiotherapy, which is what I offer. So what we do is that we give there's types of radiation that
ngifuna uyichaze kakhulu iradiation ngoba abantu banokuthi bayoshiselwa ePitori yiyo le radiation esikhuluma ngayo lokushiselwa lokho ngicela uchaze ke dokotela ukuthi nisuke nenzani nisuke nithatha iayini bashisa abantu or nenzani kahle hle.
No, not really, not literally like that. But if you think about it, so basically we use x-rays, the same x-ray that say you send when you go for chest x-ray. So those are the type of radiation that we use. So essentially. So the machine that we use is what we call a linear accelerator to deliver what we call external beam radiation. So the external beam radiation, as it describes, it comes from outside. So we just scan the patient and then let the patient go home and then decide on where we're going to deliver this treatment, and then we plan as the patient is going on with their life at home. We're using that scan. So basically we create what we call a virtual patient using the CT scan, and then we plan where we're going to deliver the x-rays there using that machine. So that's a form of what we call external beam radiation. So it cures cancer the same way as surgery, radical prostatectomy cures cancer. So it's actually like on the same level in terms of disease control. And then we also have things like brachytherapy. Brachytherapy, you can use it together with radiation, the one I've mentioned, the external beam, or you can use it alone, also in the low risk category and the intermediate risk category, which we basically either like implant what we call radioactive nucleotides on the prostate, and then it keeps on emitting radiation which kills off the cancer cells. So we don't really literally iron people.
Hey Mbukele ekhaya, sihlushwa yiso isikhathi ukuthi sincane. Ngabe Dr Mthombeni uyayichaza anabe kabanzi. Kepha ungadlulwa futhi next week Tuesday 7 o'clock khona la ku Soweto TV with Dr Pru kwezempilo. Siyabuya futhi.